that correct?
Yes.
Michael Ruppe is going to go first.
I'll go first.
Okay. Well, Michael, why don't you take it away? It's a pleasure to have you guys here, and we look forward to the talk.
Okay. Sounds good. I am going to start sharing my screen, and I think we have translation on the bottom. Can I get a thumbs up just to make sure everybody can hear me and see my slides?
Yep, we can see your slides and the translation.
Perfect. This is great. Well, thank you. And I owe Ken Remy a big thank you for walking us through the tutorial on the translation bit. So I'm actually going to talk about post-op ICU care being a cardiac intensivist, not specific to the single ventricle patient, but thank you for having me. I'm at Norton Children's Hospital in the University of Louisville. Let's see if I can get this to move forward. All right, so 3 main topics for my little bit is going to discuss the choreography of receiving a heart patient from the OR, look at a few strategies to optimize post-op bleeding, fluid overload, and low cardiac output. And then I really wanted to emphasize several of the big quality improvement things we've done in the past about 5 years that have really translated into improved outcomes for our patients. Rather than being overly comprehensive, I'm really just going to cherry pick a few select topics. This is a choreography of receiving a patient, very similar to what I think a lot of you have at your hospitals. We have anesthesia, heart surgeons, 2 bedside nurses, respiratory therapists. And the way I like to approach things is stabilize the patient first. And that means getting them from a transport to the ICU monitor safely, looking at any bleeding that may have been provoked by the ride from the operating room, looking at their bag mask ventilation, vent settings. It's beyond the scope of this talk, but the complexities of a ventilated patient after heart surgery are very important to do right up front. And then we have a typical lab panel that gets sent off. So this is all within the first several minutes of the patient showing up in the cardiac ICU. Something that's really been emphasized in quality improvement literature is a methodical approach to signing out patients. And so we wait until one of our bedside nurses is free of tasks and ready to listen, along with the rest of the team. And our surgeon begins describing the operation and any complications, the post-op echo results, heart rhythm concerns, et cetera, and then quickly hands off to anesthesia. They describe the airway, the lines, vasopressors, sedation, bleeding, bypass times, neuromonitoring, and a blood gas leaving the OR. And then an important couple of pieces that have really translated into improved outcomes. The intensivist or our nurse practitioner will then describe what the goals are, the vital signs, the plan for extubation, sedation, bleeding parameters, anticoagulation, and then our nurses and respiratory therapists chime in and are able to ask any sort of clarifying questions that they may have. And this really closes the loop on an effective, comprehensive sign out. And this is something we've only done in the past about 5 years, and it's really made a lot of difference. And then I panned out a little here, and this really is a bigger representation of a team that will receive a patient. We have charge nurses, nurse practitioners, and then ICU attending physicians. I'm not sure this is going to play, but this is, we had a patient last year, and as their right atrial catheter got set up on the monitor, the reading didn't turn out too well, and we gave some volume into the line, and the patient quickly decompensated. And so we did a bedside ultrasound, and lo and behold, large pericardial effusion. So this is just to really illustrate that you need your lines and tubes troubleshot up front. Our practice now is to draw blood out of all of our right atrial lines when they arrive in the ICU, just in case they're different than when they left the OR. An EKG is obviously done right out of the gate. This is an illustration of a patient that's not in sinus rhythm. We do use pacing wires often, and in this case, there is not a P wave that's evident, and so we did an atrial electrogram showing a different patient, but a very consistent sinus rhythm. So I don't leave the bedside until I'm 100% convinced that my patient's in sinus rhythm, and if they're not, we address that very quickly, as that can really impact cardiac output. X-rays, again, very routinely done. This is a standard X-ray of a patient. And something we've adopted lately is we really describe the depth that the breathing tubes are at, especially in newborns. And our incidence of main stem intubation and migrating breathing tubes has gone way down. And so we've gotten very methodical about lines and tubes. This patient also has pacing wires, a right atrial catheter, umbilical lines, and chest tubes, but this is a standard good-looking chest x-ray. And then bleeding. Bleeding is something that we have struggled with in the past, and I think made tremendous gains in the past couple of years. And I wanted to share my style for dealing with the postoperative bleeding patient. Our institution uses 2 mLs per kilo per hour as a goal for achieving to have blood loss under. Anything over 4 mLs per kilo per hour, we're actively dealing with coagulation parameters and transfusion, and then we bring our surgeons back to the bedside if we're unable to keep the bleeding under 10 mLs per kilo per hour. Dr. Borisino, I was listening to his talk last month, talked about replacing the blood loss acutely 1-to-1 with a combination of packed cells, FFP, and platelets. And that is a very reasonable strategy. But what we've looked at is specifically the platelet count and fibrinogen level as the most important indicator to show clot strength and therefore translate into less bleeding. I use a fibrinogen count in excess of 200 to 300 before I stop giving cryoprecipitate. And I get my platelet count over 100 or 200 in order to achieve that aggregate level that really has an effect at lowering bleeding. So cryo and platelets are a practice at my institution. This is borne out in a couple studies with small volumes of patients that really show that if you keep your platelet count, fibrinogen level up, you will have less postoperative bleeding. And we do use thromboelastographs to correct all of our coagulation dysfunction, platelet dysfunction. And once the TEG is normal and the patient continues to bleed, that's when we bring the surgeons back into the discussion. Now, there were a couple big papers in the 2 years ago. Dr. Remy's part of this, so there's a lot of people that are on Heart Care International, but this has to do with avoiding unnecessary blood transfusions. And I wanted to just highlight a couple numbers. First of all, in a non-hemorrhagic sick patient, we have gone to not giving blood unless the hemoglobin's below 7. Now that is for all comers in the ICU. In a stable, not bleeding single ventricle patient, and Dr. Figueroa will talk more about those patients coming up, we really have used 9 as the cutoff. This is for stable single ventricle cyanotic heart patients. And then a more practical approach to the acute postoperative patient, I like to think of it in terms of age and then cyanotic or not cyanotic. Our neonates who are very sick on bypass, single ventricle patients, we will give blood if their hemoglobin's below 12. For the non-cyanotic or single ventricle patients, non-cyanotic neonates, that is, we'll use 10 as a cutoff. But then 8 has really become the hemoglobin level that we will allow patients to get down to if they have heart failure or pulmonary hypertension. So we have really lowered the bar on where we are giving blood transfusion to our heart patients. Next up is low cardiac output. This is really the fundamental piece of being a cardiac intensivist, and it's challenging to diagnose. It's based on clinical exam, heart function, systemic and pulmonary vascular resistance, and then the effects of a complicated operation. So swelling of the heart, persistent acidosis, dysrhythmias, leading to a patient that's sick and has poor vascular tone, fluid overload, leaky pulmonary capillaries, and escalating need for support. And this is, I think, as different organizations push the limits on complicated neonates, this is going to be a bigger and bigger topic postoperatively, but it ends up leading to shock, and mitigating it up front is very important. So what causes this syndrome? Well, it's neonates who are on pump for a long time, have a complicated operation, need circulatory arrest, need multiple blood product transfusions, and then you add other injuries like direct incisions onto the heart, muscle bundle resections, myocardial ischemia, or an acidotic heart leading up to the operation, or a persistent acidosis during and post-op. And a lot of us who do this all day, every day, know that this syndrome occurs at about 6 to 12 hours post-op. So it's that first post-op night that is really where all of the care needs to be meticulous. And then I'd be remiss if I didn't bring up a paper from about 20 years ago now from Dr. Warnofsky and others describing the effect of milrinone to really limit the negative effect of low cardiac output. This is a slide showing that death is less when you use milrinone in patients with this syndrome. And then Santiago and others talked about the effect of peritoneal dialysis and abdominal drainage. I did want to highlight that because what they have studied in Alabama is that there are inflammatory cytokines that are released after complicated heart surgery, and it's due to transfusion and plastic of the tubing. And those chemicals lead to poor physiologic states. And if you can lower inflammation, you will improve your patient. So peritoneal dialysis does that. This is an IL-6 and IL-8 chart related to doing PD or not doing PD, and it lowers inflammation. Does that translate into better outcomes? It does. And so fluid overload is a very hot topic in the past few years. And it is well known that a 10% fluid overload percent post-op directly leads to increased mortality. So for example, at our institution, our transposition patients would have a lengthy operation, they're neonates, and they'd come back and they'd get 10 or 20% fluid overloaded in the first couple of days. They would suffer prolonged ventilation, prolonged need for vasopressors, prolonged acidosis. We started implementing PD methodically 6 hours after they arrived from the ICU, and we have lessened fluid overloaded, gotten our patients extubated quicker, and it's been phenomenal. So this is a graph of the decrease in the percent of patients that have a 10% fluid overload. We use 10 mLs per kilo of a low dextrose PD fluid with a temporary catheter. And so very sick neonates get PD, and other patients that are on the border of needing it will get an abdominal drain. And I think just draining the abdomen gets you about halfway towards avoiding fluid overload. But that has been a very big piece of our post-op care in the past few years. I'm actively involved in the Pediatric Cardiac Critical Care Consortium, which is a huge collection of heart centers that goal is to improve quality of care in both medical and cardiac patients. That website is a great reference for some of the work they're doing. And I wanted to review a few complications that they have really focused on. So first of all, how often do CNS complications occur? About 2% of the patients will have a seizure and 1% a stroke or a hemorrhage. And what can you do about it? Well, something that we've focused on is the neurodevelopmental outcomes. And we have found, this is out of CHOP, and this is that 8% of neonates undergoing heart surgery will have subclinical seizures following bypass that happens at a median of about a day post-operatively, but it leads to increased mortality. And our ability as clinicians to go to the bedside and ask the question, is this patient having a seizure, we don't do it. And so this is subclinical, and the neurodevelopmental impact remains to be seen. But my practice has been that if my newborn patient after bypass has not woken up with a reassuring neuro exam the morning after surgery, they get an EEG and an immediate neurology evaluation for seizure. I think that's made a nice difference in our neurologic outcomes. Another point I wanted to highlight is chylothorax. So about 4% of patients will get that. A lot of us know it's based on the fluid analysis and whether or not there's a large volume of fluid out. And if there is, then the patient becomes NPO and gets a special medium chain triglyceride feed. An important thing that we're discovering here is that you should try as hard as you can to discover a blood clot, a residual heart lesion, or another reason why the chylothorax has developed. And then if you have high volume output over 40 mLs per kilo per day, these patients are losing protein C, protein S, and other things that make them more likely to have blood clots. And so the conversation involves what blood thinners should they be on and how vigilantly you should check for blood clots. They get low oncotic states and need to be repleted, and then they get immunodeficient from IVIG or immunoglobulin losses. And so we have protocolized the treatment of chylothorax in a sensible way. To give you an example of published protocols, and these are very easy to find, this is out of Toronto, California, and Michigan, pretty standard approaches to recognizing, diagnosing, and treating the chylothorax patient. And that's a problem we have quite a bit. One of the last complications, I want to talk about cardiac arrest. So an incidence of 3 to 6% is very broad, and these patients are usually neonates who have underlying chromosomal problems, high preoperative risk factors, or a very high stat category implying a very high risk of death related to surgery. And this was work done through the PC4 collaborative. And something that's come out of that is a shared mental model of how to predict the patients that will suffer cardiac arrest and how to avoid it. And they this has been a great project over several years. And the fundamental tenet is to identify the patient at risk, have epinephrine at the bedside, identify vital signs that would trigger the nurse to independently give epinephrine, review all cardiac arrests, and round multiple times each day related to just cardiac arrest prevention, along with pre-sedating for noxious stimuli. So those 5 interventions have led to, among the early adopters of this bundle, a substantial decrease in cardiac arrests, which is huge as far as progress in the past couple of years. And those are the complications. I did want to leave you with a couple pictures. This is my home institution in Louisville, but I've been privileged to go to Lima and work with Dr. Ibrahim's patient that was discussed last month. And I just wanted to say, during his initial post-op course, this AP window patient had fluid given, and I think heart distension and low blood pressure. And the team addressed it in the heat of the moment and treated it with epinephrine. And it was a wonderful example of group work immediately post-op in a very sick patient. And on the bottom right is in Chiapas last year, there was a fantastic little boy who had truncus arteriosus, and the patient had a very significant amount of bleeding. And the hospital was able to get us Novo 7 and I believe factor 9 or factor 8 and stop the bleeding, which was potentially life-threatening. The patient then had, and Betsy's here, a tamponade process related to the chest tubes, and we were on it very, very quickly and stabilized him. And then that night, everybody went home, and the hospital nurses came up to me and said, "Would you like a pick? Because, you know, you need all these drugs and he's very sick." And this team swooped down, and with no orders, no red tape that would have taken 6 hours at my institution, they put a pick in this little guy, and I was in awe of the coordination. So I just wanted to recognize the collaboration that has been done on 2 really, really impactful patients. And with that, I will turn it over to Dr. Figueroa.
Hey, that is great. And then we'll take questions at the end for everybody. But the next speaker is Marty Figueroa, who's the director of transition at St. Louis Children's Hospital. And she will be giving us a talk on approaches to single ventricle management. So.
Thank you very much. I don't know if we're seeing the translation. Is the only thing. That was giving me a little bit of trouble earlier. Hold on. It's a pleasure to be here. I appreciate the invitation to be here, and it's great to see some, full faces, and you can get to meet some new folks. Let's see. I just learned how to do this from Ken, and it had been working. Okay, I think that's. Can you see my slides or no? Okay. All right. So great to see everybody now. It looks like my translation is working. Ken kind of gave me a little heart attack. He's like, "You're speaking in Spanish, right?" I was like, "I wasn't planning on it," but anyway, I'm glad we're able to have this translation for folks to take advantage of this talk. So my objectives are listed here. So we're going to basically review the current state and understanding the treatment of single ventricle disease during the 3 stages. So the Norwood, the Glenn, and the Fontan. Again, it's a lot to cover, so I may be going a little quickly, but we'll save room for questions at the end. So because of the remarkable advances in survival over the past 40 years, the worldwide population of individuals living with the Fontan circulation has grown to about 70,000, with nearly half of those being greater than 18 years of age. Survival to at least 30 years of age is now achievable for about 75% of our Fontan patients. We do know, however, that single ventricle patients, at least in the United States, account for a pretty large group of children that are hospitalized with one of the highest in-hospital mortalities. In the recent era, no congenital heart defect has undergone a more dramatic change in diagnostic approach, management, and outcomes than hypoplastic left heart syndrome. During this time, survival to the age of 5 has ranged from 50 to 69%, but current expectations are that 70% of newborns born today will reach adulthood. Although the 3-stage treatment approach for hypoplas is now well-founded, there's still quite a bit of variation among centers treating these patients. So you can see here, this is a pretty busy slide. It's basically showing the different types of single ventricle lesions, which, as you know, there are anomalies in which one of the 2 ventricular chambers is severely hypoplastic so that a biventricular repair is not feasible. Typically, the atrioventricular valve associated with the hypoplastic ventricle is also hypoplastic, and similarly, the arterial outflow valve may also be affected. There are many anatomic subtypes and variations that exist, and the nomenclature may vary, as you see on the slide. On the left-hand side of this slide, you can see a patient or a diagram of a lesion with hypoplastic left heart syndrome, and on the right, you see a lesion with hypoplastic right heart syndrome. A functional approach to the many anatomic subtypes is useful for clinical decision-making and acute medical and surgical management. The following questions need to be answered, and these include, is there adequate intracardiac mixing at the atrial or ventricular levels? Is there obstruction to pulmonary venous flow? And does either the pulmonary or systemic circulation require an open ductus for adequate flow? This table provides a synopsis of typical pre-palliation scenarios. In many forms of single ventricle anatomy, early survival depends upon continued patency of the ductus arteriosus. Ductal patency is typically maintained with intravenous prostaglandin. Most neonates with single ventricles will require surgical intervention to stabilize the parallel circulation until further palliation is possible. Initial interventions may include the creation of a systemic pulmonary artery shunt, such as the modified Blair-Lactosic shunt, pulmonary artery banding, or Norwood type procedure. Typically, neonates with functional single ventricles have a very high morbidity and mortality without palliative medical and surgical intervention, with a 90% mortality by the year of age. They may succumb to unrelenting cyanosis because of inadequate pulmonary blood flow or congestive heart failure secondary to progressive ventricular volume overload. The ultimate goal is to separate the systemic and pulmonary venous circulations, and the ultimate operation to achieve this separation is the Fontan procedure. However, this needs to be done in a staged management approach due to the elevated pulmonary vascular resistance that's present in the first few months of life. The goals are to provide sufficient blood flow to the lungs to allow oxygenation and to limit pulmonary blood flow and pressures to prevent heart failure and inadequate blood flow to the body, preventing development of elevated resistance in the pulmonary circulation and repairing obstruction to the systemic circulation. Initial neonatal surgical treatments are systemic to pulmonary artery shunts like those listed here, most commonly the modified Blair-Lactosic shunt or central shunt. And then when you have a scenario where you need to limit pulmonary blood flow, you would do a pulmonary artery banding procedure. Here on this slide, you can see the 2 modifications of the Norwood procedure. The one on the left is a Norwood with the Blair-Lactosic shunt, and on the right, you see the Norwood with the Sano shunt or the RVD with PA conduit. The goals of the Norwood surgery are to provide unobstructed systemic blood flow, to limit pulmonary blood flow, provide unobstructed pulmonary venous return by creation of an ASD, minimize the likelihood of pulmonary artery distortion, and avoid dysrhythmias. Post-op Norwood physiology, the goal is to have a balanced circulation so that volume work is minimized. However, we all know that this is sometimes difficult to achieve. Initially, the ventricle has just been through hypothermic cardiopulmonary bypass with myocardial ischemia. You have the systemic inflammatory response that results as a result of injury to the vascular endothelium. And then you have a ventricle that can exhibit this low cardiac output anywhere from 6 to 24 hours post-op. The management of the post-op Norwood patient is probably one of the more challenging, but for cardiac insensitive is probably one of the more fun surgeries to take care of. I think the two major categories are going to be management of low cardiac output syndrome, as well as balancing of the circulations or the flow to the lungs versus the body. In terms of strategies for management of low cardiac output, it includes optimizing the ventilation strategies. What I mean by that is your cardiopulmonary interactions. That's a whole discussion in of itself, but paying attention to that. Optimization of your inotropic supports, careful management of fluids, avoiding drugs with cardiovascular toxicity, and management of arrhythmias. Certainly for some of these patients who are very sick and do have events post-Norwood, ECMO is also an option. In terms of managing the PDQS, there's different strategies for management of pulmonary vascular resistance issues. Again, ventilation, optimization, use of nitric oxide as a pulmonary vasodilator. Management of the aortosystemic shunt is also important to standardize. At our institution and many institutions, they utilize heparin infusions post, as well as early aspirin therapy. There also needs to be high index of suspicion when you have a patient who is having hypoxemic episodes in the post-op period, and really need to investigate that, as interventional techniques have really come a long way, and certainly that can get you out of a very difficult situation. Management of the SVR is probably one of the things that needs to be recognized pretty early for a lot of these patients, as they can definitely lead to early circulatory collapse. Probably phenoxybenzamine is probably one of the most studied drugs in this early postoperative period, and has been shown to reduce sudden cardiac events postoperatively. Oh. Okay. So on this slide, you can see this is kind of an older study, but it's the single ventricle reconstruction trial, which basically compared the two shunt types. Sorry, my computer's doing weird things. And basically looked at the primary outcome of death or cardiac transplantation after randomization. Secondary outcomes included post-op morbidity, post-Norwood, and RV function and pulmonary arterial growth, as well as neurodevelopmental outcomes. I'm having some technical difficulties here. Can you guys hear me? Can you guys hear me?
Yeah.
Sorry, my slides are not advancing here. And the translation is quite amusing. That's pretty funny. I'm sorry, I'm not sure what's happening. Anyway, on this slide, you can see the hybrid palliation, which consists of bilateral pulmonary artery banding and PDA stenting, as well as an atrial level stent. My computer is acting up. I'm so sorry. Okay. Indications for hybrid palliation are basically institution specific with no current consensus on procedures in patients with hypoplastic left heart. A lot of institutions will just basically take high-risk patients for hybrid palliations, while others, like the Columbus group, will do hybrids on all their patients. This publication out of Brazil looked at a adjustable pulmonary artery banding procedure for patients with hypoplastic left heart with good results as a stage approach to a comprehensive stage 2. And this publication out of Germany also looked at a modification of the hybrid as a stage approach to the comprehensive stage 2. Second stage management for single ventricle, the goals are to reduce the volume load on the single ventricle and maintain adequate oxygenation. These surgeries include the bidirectional pulmonary shunt or the Hemi-Fontan procedure. The bidirectional blend procedure consists of RV to PA or BT shunt takedown, as well as anastomosis of the superior vena cava to the right pulmonary artery. This slide here basically shows the different steps in the creation of the bidirectional blend. Hemi-Fontan is similar to the Glen, except that it has an additional proximal superior vena cava and inferior right pulmonary artery anastomosis, with the right atrial communication being closed with a patch. The Hemi-Fontan is usually used in centers where the lateral tunnel Fontan is performed. And again, this is just showing the different steps with the Hemi-Fontan. The stage 2 physiology, your QP to QS is now going to be closer to 0.5. Your saturations range anywhere from 75 to 85%. Your excessive volume load is now eliminated with the single ventricle now pumping only to the systemic circulation. Your decreased cavity dimension and increased wall thickness results in improved tricuspid valve function. Again, postoperative issues, the goal would be to extubate these patients in the operating room. However, we do have patients that do require mechanical ventilation. So close attention to minimizing the airway pressures on the ventilator are very important, as these are going to affect your flow through your blend. Low cardiac output needs to be recognized early. This can be due to decreased ventricular function. Sometimes we have patients who have aortopulmonary collaterals that have not been recognized prior to going for the Glen, and so these need to be addressed in the post-Glen period. AV valve regurgitation, and then certainly loss of AV synchrony is something that can be minimized with pacing. So again, careful choice of inotropes. Most places will use milrinone for these patients. You want to avoid medications that are going to cause tachycardia, as your passive pulmonary blood flow is going to occur mostly in diastole. Alpha agonists, since they work on both the pulmonary and systemic vascular beds, can have deleterious effects on the post-op ventricle. Elevated SVC pressures. So, if you have a patient who has upper compartment plethora and swelling, you need to think about the differential diagnosis being either a Glen obstruction, elevated pulmonary vascular resistance, or pulmonary artery distortion, and certainly address that early. Prolonged pressures, elevation of pressures in the SVC can certainly lead to cerebral edema. So moving on to the last stage of the Fontan. So basically with this last stage, you're completely separating the systemic and pulmonary venous circulations. Again, short-term rest, a lot of these patients are in the hospital with pleural effusions, and so there's been several modifications throughout the years to try to reduce length of stay secondary to pleural effusions. Longer term, we're seeing a lot more of these patients presenting with protein losing enteropathy, cirrhosis, and arrhythmias, and a lot of them are being referred for evaluation for transplant. So here you can have the three sort of the three versions of the Fontan procedure. On the left, you see the initial atrial-pulmonary Fontan, which we probably don't see much anymore. You may have some adults with atrial-pulmonary Fontans out there. But basically, the downside to this type of Fontan was the fact that you had development of a massively dilated and hypertrophied right atrium that put these patients at risk for tachycardia. The extracardiac Fontan on the right on the slide is a technically simpler procedure that is easily taught to trainees. It is more reproducible even in the setting of atypical anatomy. It can also be performed without cardiopulmonary bypass, so that offers an advantage as well. The important disadvantages with this approach are that it is more difficult to fenestrate and there's no growth potential. In the middle, you see the lateral tunnel Fontan, which requires, again, more surgical expertise and judgment. It does tend to have a heavier atrial suture burden that in some animal models has led to more inducible tachycardias. However, these lateral tunnels are easier to fenestrate and you can have easy access to the left atrium for if there is a need for intervention. This last modification, okay. I was going to show a picture of the, I don't know why my mouse is not working sometimes. Of the intra-extracardiac Fontan modification that was initially described by Dr. Jonas. Again, there's certainly the Washington, D.C. folks tend to use this even in patients who don't have a normal venous anatomy. There we go. So post-operatively, the Fontan Physiology, QP to QS is equal, with the ventricle supplying the entire cardiac output to the systemic circulation. Again, your pulmonary flow is non-pulsatile. Again, you know, the main goals post surgery are to have early extubation in the OR, as positive pressure can increase your pulmonary vascular resistance and affect your Fontan flow. However, if you do have a patient that is comes out to the ICU intubated, you want to again minimize your peak, as that can also increase your PVR and make sure that you're minimizing positive pressure, your peak inspiratory pressures. Again, low cardiac output, you know, can have a variety of causes, so it's important to be able to define those. In the Fontan, you have to worry about inadequate preload. Again, you know, thinking about pulmonary vascular resistance, if there is a risk, certainly if there's any anatomic obstruction, and again, any causes for potential pump failure. Cyanosis is basically, you have to think about pulmonary venous desaturation, systemic venous desaturation, and decreased pulmonary blood flow. Arrhythmias can also be seen commonly, and so we rely on those temporary pacing wires to make sure we establish AV synchrony. And here you can see the results of the DC experience with the intra-extracardiac Fontan, and you can see that they showed early results with decreased length of stay due to decreased chest tube need for chest tube days. And then this is a publication in 2019 from the Japanese group, also showing pretty good results with the intra-extracardiac modification. I just want to kind of give kudos to our team here who takes care of the single ventricle patients. You know, again, like previously mentioned, this is a multidisciplinary approach. I have people that I probably haven't mentioned on this slide, but it truly does take a village. And then again, also highlighting the power of learning collaboratives and quality improvement collaboratives. Again, PC4, you know, certainly the National Pediatric Cardiology Quality Improvement Collaborative has done a lot of work with the single ventricle patients, and then out of that came the Fontan outcome Rodolfo, who's also doing a lot of work. So in conclusion, there continues to be a focus on underlying mechanisms of heart failure, arrhythmias, pulmonary and lymphatic vascular abnormalities in this patient population, quality improvement and research are crucial to maintain long-term performance. I think that's all I had. Thank you. Sorry for the technical problems.
No worries. Outstanding talk, and we'll save any questions to the end. And for our last speaker, we have the honor of having Rodolfo Espinosa, who is one of the cardiac anesthesiologists and exceptional cardiac anesthesiologist from Tuxtla in Chiapas. I've had the pleasure to work with him on several mission trips, as well as he's now become one of our critical members of our anesthesia team. And he's going to talk about anesthesia for the single ventricle. Rodolfo, if you want to share.
I can. ¿Dónde puedo cargar la exposición? No. ¿Alguien me puede ayudar cómo cargar la exposición?
Alistair, can you help him in how to share his presentation? Alistair?
Rodolfo, where is your presentation right now? Is it on your desktop?
Yes,
My computer.
Okay, so when you go to share screen, you'll see a bunch of different screens that'll pop up. If you don't see your PowerPoint, scroll down to look at all of it, and it'll show up in that screen. It'll be when you move your cursor at the bottom of your Zoom, it'll say share screen, and then it'll pop up a bunch of different windows with different views of what your desktop. There you go. You're on it. You got it.
Okay. So now we need. Can you talk them into to translate into English, or should we just leave it?
Rodolfo, are you by chance, do you have a Microsoft account?
Yes.
No lo tengo.
He might not.
¿Tienes cuenta de Microsoft? Rodolfo, para traducirlo en inglés o sí.
No, creo que no lo tengo eso.
Sigue.
No, ok.
Perdón, ajá.
Ok. Vamos a ver lo que es. Primero, gracias por la invitación al grupo de Healthcare. Y vamos a ver el aspecto de que es el anestesiólogo, que siempre somos, no tanto relegados, pero sí es un punto crucial en el cual participamos en el trinomio en el cual es el perfusionista, el cirujano y el anestesiólogo que está en sala para la atención del paciente. La planeación de la anestesia empieza desde que se nos presenta el caso, la cardiopatía congénita que vamos a tratar, en qué condiciones está ese corazón y ver qué tanto daño tiene ya esa pared miocárdica en el cual nosotros podemos trabajar y qué tanto la podemos forzar para el acto quirúrgico. En final de cuentas, nuestro plan anestésico se va a convertir todo en objetivos y metas en los cuales nosotros tenemos que cubrir paso a paso del proceso tanto anestésico como el quirúrgico y el postoperatorio inmediato en sala, en el cual tenemos que cumplir esas metas para darle el beneficio, como dijo Mayte, de la extubación temprana a esos pacientes. Siempre al anestesiólogo nos han visto como que es el piloto de un vuelo, de un vuelo aéreo, en el cual nos estamos encargados de unos ciertos controles en los cuales nos encargamos de la inducción anestésica, es el momento del despegue del paciente, el transanestésico, que es mantener el vuelo, y el el momento de la emersión o del despertar del paciente, que sería el aterrizaje del avión. Pero, a menos en lo que yo percibo, el anestesiólogo cardiovascular pediátrico es otro aspecto. No se tiene que solamente que fijar en eso, sino que siento que es el director de una orquesta en el cual tiene que coordinar en qué momento entra cualquier tipo de procedimiento que se vaya a hacer, sea per se la cirugía que se conlleva, en el cual tiene que llevarse a cabo este procedimiento quirúrgico, en el cual tiene que coordinar los tres aspectos y tiene que coordinar toda una sala de quirófano para poder llevar todo a bien. Y en sí, este es nuestro ambiente natural en el cual estamos trabajando por lo regular en un procedimiento de cirugía cardíaca con circulación extracorpórea, en el cual está el equipo quirúrgico, que es a base del cirujano y su ayudante y su enfermera quirúrgica, el perfusionista que está acompañado de su ayudante y por ende el anestesiólogo que está aquí atrás escondido, pero trabajando, ténganlo por seguro, en el acto quirúrgico. Y los objetivos cuales tenemos que cumplir nosotros como anestesiólogos, pues tenemos que ver cada aspecto de cada paciente, como ya se lo mencioné al principio. Tenemos que, por lo regular, premedicar al paciente en la sala de preanestesia, en el cual el niño ya llega bajo efectos de sedación, le damos una inducción inhalatoria con sevoflurano, que es lo más común que contamos a la mano, y ya debemos de haber preparado qué medicamentos y qué drogas vamos a utilizar con este tipo de pacientes. Y algo que es ya regla normal es que debe de estar totalmente, todas las jeringas deben estar rotuladas para no cometer errores en caso de alguna emergencia. Y esta en sí es la gama de medicamentos en los cuales nosotros podemos, si se toma la palabra, podemos jugar o podemos echar mano para llevar a cabo un acto anestésico de manera adecuada, sabiendo las condiciones de ese corazón o de ese paciente en las cuales está y en el cual nosotros podemos utilizar toda esta gama de posibilidades en el cual este cuadro solamente refleja en el cual es los primeros pasos de la anestesia en el cual son sometidos los pacientes. Posteriormente ya tenemos y usamos una cantidad infinita de medicamentos en los cuales podemos iniciar. Y esta gráfica aquí no le puse más que este símbolo, pero ¿qué factores pueden influir para que una cirugía cardíaca se pueda llevar a cabo con éxito? Y por eso le puse el signo de infinito, porque son una infinidad de cosas que se tienen que conjuntar para poder llevar a cabo una cirugía cardíaca. De esto, Betsy nos podrá decir millones de anécdotas en las cuales nos conllevan a que un niño pueda ser operado desde el traslado de su casa, desde mantener los insumos, desde el mismo personal del hospital, en fin, por eso no me alcanzaría, yo creo que la exposición a decir la cantidad de factores que se involucran para poder llevar a cabo una cirugía cardíaca y por ende, pues poder realizar esta operación. Por lo regular, el primer obstáculo o el primer objetivo que nos debemos de tener es la vía aérea difícil o la vía aérea común de los pacientes que raramente, por ejemplo, los niños que son sin síndrome de Down, se considera vía aérea difícil. Por ende, la cardiopatía que contienen estos niños también es ya grave. Entonces, el primer obstáculo y que lo que hacemos día con día es la intubación, en el cual puede ser un procedimiento muy sencillo o puede volverse toda una catástrofe en el caso de que no podamos llegar a tener una intubación exitosa. Por lo regular, contamos con estos insumos, que es el tubo endotraqueal, las hojas de laringo, que según ya sean las rectas o las curvas que se utilicen, y las cánulas de Guerrero, que son las que regularmente usamos para intubación. Pero actualmente ya contamos con ciertos dispositivos de tecnología ya avanzada que nos apoyan y nos ayudan en nuestra labor cotidiana en el cual nos podemos llevar a cabo esto, que por lo regular los hospitales no se cuenta con este hospital, al menos de lo que yo he visto en México y en Latinoamérica, es poco común que se cuente con estos insumos. Por lo regular nada más contamos con un laringoscopio, en el cual el anestesiólogo tiene que desarrollar la habilidad para poder cumplir el primer objetivo y lograr la intubación de ese paciente. Una vez que logramos esa intubación, ya debimos de haber monitorizado al paciente y debemos de haber tenido cuando menos todos los parámetros hemodinámicos preestablecidos antes de empezar la inducción anestésica para saber en qué condiciones y para saber también qué medicamentos vamos a utilizar y la dosis en las cuales vamos a administrar a ese paciente para mantener la estabilidad hemodinámica y no complicar la cardiopatía que por sí tienen. Otro de los obstáculos que tenemos y que el cual batallamos seriamente el anestesiólogo cardiovascular es la instalación de estos catéteres, que es ya sea por vía yugular, ya sea por vía subclavia o por vía femoral, en los cuales podemos llegar a instalar una línea central en el cual nosotros tenemos que instalar porque necesitamos tener estos insumos, esos implementos para poder administrar los medicamentos o lo que tengamos que administrarle en un momento de la cirugía. Otro obstáculo que tenemos es la canulación de una vía arterial en el cual no es nada sencillo, aparentemente se ve muy sencillo, pero no es nada fácil y por ende también tiene su dificultad. Y la vía periférica, que esa es afortunadamente todos los días hacemos esto también, en el cual debemos de tener ya sea una o dos vías periféricas en las cuales según la apatía y el acto quirúrgico nosotros podemos llegar a instalarlo. Y lo mismo, actualmente ya contamos con ondas de ultrasonido en el cuales nos puede dirigir y hacia dónde va a ser la punción sin llegar a tener que lesionar la arteria en el caso de que queramos tener una línea arterial o una vía venosa, perdón, y no lastimar una vía arterial, que también sería no bueno o una complicación de este tipo de técnicas. Y en anestesia, en sí, lo que hacemos siempre es aplicar múltiples logaritmos. Según el logaritmo, en el momento que estemos llevando a cabo la anestesia, vamos a llevar el logaritmo de la vía aérea, vamos a llevar a cabo el logaritmo del sangrado quirúrgico, y en sí, todos siempre tenemos que tener en mente, cada anestesiólogo, esos algoritmos y tenemos que estar repasando 1, 2, 3 veces durante el procedimiento quirúrgico para que todo se lleve a cabo. Y al final de cuentas, la anestesia es esto, como bien nos dijo Mike, todo ya está escrito y todo ya está dicho, en el cual hay logaritmos y secuencias en los cuales nosotros tenemos que hacer para que podamos llevar a cabo bien el acto quirúrgico. Los implementos y los insumos que tenemos extras, que contamos en sala de quirófano, pues son estos implementos en el cual debemos de contar primordialmente con una máquina de anestesia adecuada, que aunque parezca ilógico, no en todos los lugares de Latinoamérica se cuenta. Por lo regular, siempre son máquinas de anestesia más sencillas, entonces debemos de obtener este tipo de máquinas. Si se cuenta con este aparato avanzado que es el NIRS o el otro que es para saturación regional, el SPO3, que es mejor conocido, en el cual nosotros podemos llevar a cabo, tener la vigilancia de la oxigenación regional. Y en sala de quirófano, en caso de que haya alguna complicación o algún evento de desfibrilación al momento de salir de bomba, pues tenemos el desfibrilador para poder llevar a cabo este procedimiento. Y el electrocauterio y el aspirador, que pues son insumos complementarios del acto quirúrgico. Y en sí, todo lo que nos compete al anestesiólogo cardiovascular se envuelve en estos tres grandes rubros, que tenemos de tener adecuadas bombas de perfusión para poder administrar los medicamentos que conlleven o que según la cardiopatía congénita que estamos operando, al momento de que nosotros queramos estimular ese corazón, podemos darle el manejo adecuado. Las soluciones periféricas igual deben de estar perfectamente bien tituladas y señaladas para poder saber qué es lo que estamos administrando. Y la adecuada vigilancia hemodinámica es crucial en este tipo de procedimientos. Es impensable poder llevar a cabo una cirugía cardiovascular sin estos tres elementos y sobre todo que haya la ausencia de uno. Y en sí, como ven, el escenario del anestesiólogo no es estar vigilando las manos del cirujano, pero sí estar al pendiente de qué está sucediendo en el acto quirúrgico en algún momento de que se llegara a suscitar algún accidente en la sala de quirófano y que se llegara a presentar un imprevisto, estar al pendiente y saber en qué momento estamos de la cirugía y poder actuar de manera inmediata y sobre todo en perfecta comunicación con todo el personal que está en la sala de quirófano. Esta gráfica es una representación de lo que sucede con la bomba de circulación extracorpórea. La puse porque está más que estudiado que es una agresión, se cataloga como una respuesta inflamatoria sistémica severa, como similar al estado de sepsis, en el cual ese paciente está siendo sometido, aunque sea una cirugía de comunicación interauricular o una CIB, la salida de la sangre del cuerpo humano sufre esta agresión y sufre todo ese proceso inflamatorio en el cual nosotros tenemos que lidiar para poder llevar a cabo para el bien del paciente. Entonces, los sucesos perioperatorios también que debemos de tener en cuenta es la anticoagulación. La anticoagulación es necesaria para poder llevar a cabo la circulación extracorpórea de manera adecuada. Pero después que lo sometemos a una severa anticoagulación, al terminar el acto de la circulación extracorpórea, queremos que todo vuelva a la normalidad. Bien decía alguno de mis maestros, parecemos que entramos en estado psicótico, en el cual primero queremos que sangre y después no queremos que sangre. Entonces, en un periodo de tiempo muy corto, que estamos hablando de 2-3 horas, en el cual es sometido esas alteraciones de la coagulación, en el cual nosotros tenemos que saber cómo poder revertirlos, ya sea con la heparina, con la protamina. La temperatura, que por lo regular los manejamos en normotemia, pero si son cirugías o procedimientos quirúrgicos más severos que requieren una hipotermia más severa, entonces también tenemos la implicación de eso. Los trastornos electrolíticos de por sí, los niños cardiópatas ya con todos los medicamentos y con todos los trastornos ya conllevan que lleguen con alguna alteración electrolítica. Los eventos adversos en los cuales podemos citar son iguales, son un sinfín de números. La hemodilución sanguínea, la cual es sometida a la circulación extracorpórea, también es muy severa, en el cual ahí vemos qué tan buen perfusionista tenemos, en el cual pueden llevar a cabo un evento de circulación extracorpórea y una vez que termina la circulación extracorpórea, regresar toda la normalidad verdaderamente es de una labor titánica. Y esto es lo mismo en lo cual cuando el paciente está en circulación extracorpórea, lo metemos a un estado de asistolia en el cual tiene que ser sometido para que pueda ser reparado ese corazón y en el cual igual sucede. En un periodo breve de tiempo, queremos que ese corazón esté latiendo como que si no hubiera pasado nada y que estamos todos felices y contentos. Al final de cuentas, todo eso es la labor que necesitamos hacer antes y durante la cirugía, durante la circulación extracorpórea, para que una vez al destete de la circulación extracorpórea, toda la agresión que sufrió ese cuerpo humano y la salida de sangre que se está sometiendo a este paciente sea lo menos agresivo posible y que todo regrese a la normalidad. Y una vez que ya terminamos el acto quirúrgico, pues una etapa más igual de crítica, no tanto, es el traslado del paciente al área de terapia intensiva, porque igual pueden pasar diversos sucesos y eventos en los cuales desde la subida y bajada de bombas pueden desestabilizar al paciente, no llevarlo dormido, si en caso de que saliera extubado, no llevarlo dormido y que se fuera despertando durante el traslado, también eso es muy, muy delicado. Y en caso de que, por lo regular, que los hacemos a extubación temprana en sala de quirófano, que no vaya con una adecuada analgesia y que vaya presentando dolor del niño. Entonces, en esa etapa. Y esto es, por lo regular, lo que siempre nos topamos y nos encontramos en las salas de la terapia intensiva en Latinoamérica, en el cual nosotros tenemos un sinfín de cables y cosas en las cuales tenemos que tener la vigilancia y explicarle perfectamente bien al equipo de enfermería y al médico responsable del área de terapia intensiva cómo van los medicamentos, cómo van las diluciones, cómo estuvo en ventilación, cómo estuvo en sala de quirófano, cuál fue su comportamiento en general, para que él sepa a qué escenario se va a enfrentar y sepa qué es cómo actuar en caso de alguna eventualidad. Y eso igual ya Michael lo explicó perfectamente bien. Y en sí, esta será mi última gráfica, en el cual veo que el anestesiólogo cardiovascular tiene que formar estos elementos en el cual tiene que mantener en equilibrio toda la hemostasia del cuerpo humano, que tiene que ver la reacción inflamatoria sistémica, revertir la reacción inflamatoria sistémica, revertir el daño pulmonar, tratar de ser lo menos dañino en lo hematológico, que no haya una función renal y una función cerebral adecuada, con un estado de anestesia y un estado de analgesia normal. Y con el equilibrio gasométrico, electrolítico y emocional. Entonces debemos de tener este adecuado equilibrio. Esta es, muchísimas gracias.
I think you had a really good.
What?
I gotta go.
All right. Bye.
Yeah.
Anything up?
Yeah.
All right, bye.
Hey, that was some great talks. Thank you, Rodolfo. But oh my gosh, if anybody has any questions, but I will start. I think the key thing that has come across with all three of the talks, and Mari, if we can start with you, is the team approach and the communication. What are some of the strategies that the transitions of care are critical, especially for single ventricles? And you're the director of the high risk follow-up clinic at St. Louis Children's. How is it that you take a patient that is transitioned from, for example, a Norwood to a bidirectional Glenn? What are the critical pieces of the team and the communication that ensues to decrease errors?
Yeah, so, you know, I think communication is definitely, like you said, key. I think the transition periods, you know, the transition to home after the Norwood is probably one of the key times for these patients, because a lot of times their management can be quite complex. So at least, you know, here we send a lot of our kids home with NG2 feeds, and that seems to be probably our more challenging scenarios. And we do follow a lot of these patients with our referring cardiologists. So, you know, they, you know, we have a fair number of patients that don't live close to St. Louis Children's, and for those patients, we need to make sure that we're in close communication with their referring cardiologist, with their pediatrician. And so we have processes in place for ensuring not only readiness for discharge, but then communication with all the key parts of the team. So that's, I would say that's probably our most critical is our Norwood interstage, and then bringing them back in for Glenn. Once they receive their Glenn, we will see them for 1 or 2 times, and then we kind of hand over care back to the either the referring cardiologist who we're co-managing with, or with local cardiologists. Usually that's a formal communication, verbal communication, as well as sending the records over. So we do have processes in place for all those phases.
Michael, for you, you talked about the handoff. One of the big things that a lot of people are doing are team huddles, and this goes to all 3 of you. Actually, if you can answer this, is the importance of that communication and developing expectations for the patient prior to going into the operating room. How important do you think that is, and what strategies can be done to improve that so that everybody is on the same page?
Mike, before you answer that, would you do me a favor? Will you just share a screen with a blank slide so that underneath it, you could translate in Spanish when you talk?
You're asking a lot.
Yeah, but you'll be able to handle it, I bet you. You did train me.
Man. All right, I'm going to just go back to my talk. Did this?
Yeah, just perfect. Yep, right there you go. Thank you.
Sure. No, but Alistair, your point is very well taken. I didn't even talk about the pre-op conversations around patients, and that has been sort of standardized as well. A couple things we do is we have patients that we keep down and out, so sedated and paralyzed their first post-op night. We have protocols for mitigating pulmonary hypertension, or for a rapid plan for extubation in the immediate post-op period. So we huddle with our charge nurse, and we do safety huddles twice a day. We do it in the morning around the time of our surgical rounds, and then in the evening. And we talk about which patients should have be on a watcher list, be on a list for expecting them to have a decompensation or limited suctioning, limited sort of noxious stimulus. So for instance, we have a Norwood patient came back yesterday. We had preoperatively rounded with the NICU, talked to our nurses about which sedative meds to use. Our anesthesiologist was there, and we kept the patient intubated and deeply sedated with the option to use a paralytic already when they immediately showed up post-op. And so safety huddles have become sort of a part of the culture at our institution. They've really helped to be inclusive of the rest of the care team, and particularly nurses and therapists. When they're part of the process, I think there's a lot more opportunity for education and buy-in about the overarching plans for the patient. And I think the energy in our hospital has improved immensely because of that phenomenon.
I think we do a lot of the same. I think another important piece that I hadn't always seen at other places that I had worked is our surgical and cardiology team followed, but they all send preoperative briefs via email to all the teams involved, and so there's a detailed plan of what the surgeon is thinking in terms of what the procedure is going to be, what the access is going to be, any special equipment, what the post-operative plan is going to be. We have a lot of the same huddles that Michael described. The huddle from the OR to the ICU is kind of a sacred time, and it's just done automatically, like at a lot of places. But we've also incorporated that process into our transfers of care, for any procedure. So for cath lab, EP lab, not only to the ICU, but also to the step down unit. And the same thing with the briefs. The cardiology proceduralist also will send out briefs not only to the team here, but also the referring cardiologists are also included in that. So.
Well, these were great presentations. Does anybody have any questions?
Hi, this is Betsy Jr. I have a question regarding how, now that you're doing the handoff, do you take into consideration the nurse that's accepting the patient and what their level of skill is? So like right now, currently, we're really struggling with the number of seasoned nurses that we have and that we've been able to post-op train. So do you ever, from the surgical perspective, when you're bringing a patient, take that into consideration in the way you give report to these nurses?
Well, that's a really relevant and important question. We are really blessed, I think. There's a lot of conversation about smaller hospitals actually having a little better retention of the seasoned nurses. And we've had an administrative change that has enabled us to have nurse educators and a much more well laid out hierarchical system, so that for our patients, we really do have probably more resources than we had in the past. We don't have, and we pair it with the acuity. So our volumes are down a little bit. I think a lot of surgical volumes are down this year. And so we have not dealt with inexperienced nurses being put into positions where they're taking care of very high risk, extreme neonate cases without the supervision of a senior level nurse. When that arises, we have nurse educators that have actually kind of filled in a lot of the gaps, and we really have used nurse practitioners. We have about 5 full-time nurse practitioners in the cardiac ICU that will have sort of one-on-one education about the lesion, about the post-op concerns. And right now we have the bandwidth to try to jump on the inexperienced nurses to improve their education about the patient in front of them, and then on a more global level. So it's a very real problem, and I think every place has their own resources to handle it.
Thank you.
I do have. Oh, go ahead. I was just going to tailor off of that from a nursing perspective, Betsy Jr. We started just over the past, I don't know, probably 2 months, doing more of a virtual handoff starting in the OR. I work as an NP on the surgical side of things, and with everything going more virtual, we have started doing more of a handoff starting in the OR and then following that through from our OR to the bedside. It certainly comes with a lot of challenges, but it's something we're kind of working through with each team from an anesthesia perspective, perfusion perspective, surgical to the CTICU with the intensivists and the APNs and bedside nurses. So it's certainly multifaceted, but we've learned a lot from it, from each team, and it'll be interesting to see how that grows.
Are you using a specific program for that, or like a chat room, just texting?
Typically WebEx or something that we can do securely, but we want to try to make it more so it's like this, where you can physically see the person, or you can see the monitors and the screen in the OR. So technology wise, we're still working out as well, but it's been interesting, but I think it's certainly improving a lot of that communication from team to team.
Awesome, thank you.
Yeah.
I wanted to ask, this is Carlos Montoya. First of all, congratulations to the whole heart care team for putting this together. I found it fascinating. And sometimes when you're an old dinosaur who had done ICU many months ago, the more things change, the more they stay the same. There was a point, and Betsy Tirado may remember this, that we used to keep all arrest medications labeled by the bedside. And it's refreshing to know that, Michael was talking exactly about that. And when to actually use and give the responsibility to a nurse or a senior nurse that recognizes an impending arrest to give epinephrine. I think for Latin America, that will be a huge accomplishment. And I know that Betsy has worked a lot in education in Central and Latin America to actually empower the nurses to make those decisions. But I would like to ask Mayte and Michael and Ken and then, you know, anybody who wants to chime in, how do they see that happen?
Can I, I'm gonna chime in. So one of the things that we have decided to do with heart care right now is we have offered to 4 of our host countries. We are sending the nurses to be NALS and PALS certified. Historically in these countries, they are not. They may not even have basic life support training. This is not offered by the hospitals. So this it's part of the educational component of heart care. And we're sending 2 nurses from each country. So or each sections, we're actually sending 2 from Chiapas, 2 from Mexico City, 2 from El Salvador, 2 from Peru, and 2 from Dominican Republic to get now to be PALS and NALS certified. The goal eventually is to get everyone on board that way, that if you're gonna work in these areas, this is the minimum. But also the goal is to eventually get them to be instructors so that they can continue the a program, establish a program and do it themselves. Right now, Dominican Republic does not have PALS or NALS, but Puerto Rico does. And so we're considering sending them there. El Salvador has it. Peru does not. So the nurses from Peru will probably need to go to Florida, and then, but that's our goal. And it's to empower the bedside nurse to be able to make these decisions. If they don't have this education, if they don't have this background, this is something really hard to obtain. So I think us helping them to become certified, it's going to help them. It's going to help in the long run.
Betsy, I think this is brilliant. I might just add one caveat if there is an interest on the heart care side. So I've been a PALS, ACLS, and BLS instructor now for 17, 18, 20 years, I think now. If we had a donor that would like to donate money for us to buy a set of mannequins, and then I would be more than happy to go on these trips and frankly only just hold PALS and BLS classes and get everyone certified before I leave at each of the locations. That would be relatively easy. The rate limiting step, honestly, is 2 things. One, which is, and especially because now with American Heart Association, we've actually moved away from a lot of the in-classroom learning, and we do a fair amount of online heart codes. And so I can actually be able to send the heart codes to folks where we're going and then just go down there, and we can do it that way if we could get our hands on at least some mannequins.
Okay, that, you know, the thing is, it's, will you be able to certify them? Because that's the goal. They need to be able to be certified, because, so that's another talk. We can talk about this off this panel. And I have like a baby Annie. So I bought my own baby Annie. This is how I used to teach. So I don't have a bigger one. I just have the little one. So
I can
I think this is,
I would babysit your Annie.
Yeah, let's take this offline. I think this is a great conversation, and there's a lot we can do regarding that. And I think that's a great idea, Ken. But time is short for this call. Does anybody else have any questions? If not, I want to really thank the speakers. They were outstanding, and I think they gave a lot of great information. If Margaret had put in the chat, if you guys can send her the slides so that we can put it on our website. But thank you very much. I think this education series, the Grand Rounds, the purpose is to improve the communication amongst our team. And we will be asking others to participate and give talks, but these have been outstanding. And thank you everybody for participating and listening, and thank you for the talks.
Great to see everybody.
Great to see you.
Bye, nice to see
Thank
you.
you so much.
Bye, thank you.
Bye.
Everybody, thank you.
Bye.
Thank you. Bye. Wow, yeah.